Muscles that work perfectly at dawn but completely fail by dusk. And get this, one wrong medication can stop your patient's breathing entirely. Welcome to today's NCLEX Explainer, where we are mastering myasthenia gravis. That terrifying scenario is the intense daily reality for these patients, and honestly, it's exactly why board examiners are completely obsessed with this topic. You absolutely have to know how to keep these patients safe. So let's kick things off with the core problem, the pathophysiology. To really understand the why here, we have to zoom way in to the microscopic level. Right at the neuromuscular junction, these rogue autoantibodies start attacking. They literally block or completely destroy the acetylcholine receptors. Now, acetylcholine is basically the VIP messenger that tells your muscles to fire. When those receptors are blocked, the muscle gets a weaker and weaker signal. It's kind of like a fraying phone charger cord. Because of this terrible connection, repeated use just exhausts whatever little transmission is left, leading to this classic fatigable weakness. The muscle just gives out. Okay, moving into signs and symptoms, the clinical picture. Let's zoom back out and see how this failing connection actually looks on the floor. You are going to see a hallmark descending pattern of weakness. It starts high and goes low, and crucially, it gets notably worse with activity. So it starts at the eyes with ptosis, drooping eyelids, and diplopia or double vision. As the day wears on and they keep using those facial muscles, you'll actually see their smile fading away. That leads to difficulty chewing, slurred speech, and eventually dysphagia, which is trouble swallowing. But here is the massive red flag you have to watch out for. Decreased respiratory effort, difficulty breathing, and a weak cough. Listen, respiratory failure is the absolute most critical emergency here. It's the one thing that can actually kill the patient. Which brings us to priority nursing interventions, your ABCs and management. Because of that severe respiratory risk, your nursing priorities need to be laser-focused. In order of priority, number 1, you must monitor that airway. Always keep section and emergency airway equipment right at the bedside. Number 2, implement aspiration precautions. Assess their swallow, keep them upright, and carefully plan meals for when they're at their absolute strongest. And number 3, you have to perfectly time their medications. Beyond these basics, you'll probably also see management strategies like immunosuppressants, plasmapheresis, IVIG, or even a thymectomy to stop those autoantibodies at the source. Now, speaking of medications, pyridostigmine is your cornerstone treatment. It's an anticholinesterase that essentially boosts the available acetylcholine in the junction. The golden rule here? You absolutely must give it 30 to 45 minutes before meals. This guarantees they have peak muscle strength for chewing and swallowing, which prevents them from choking while eating. Missing this medication window is a huge safety hazard. All right, get ready, because here is the classic NCLEX trap: myasthenic versus cholinergic crisis. What happens if those medications get unbalanced? This is the exact spot where students lose points on the boards. Both of these crises cause life-threatening respiratory failure, but the causes are total opposites. A myasthenic crisis happens from too little medication, or maybe a trigger, like an infection. On the flip side, a cholinergic crisis is from way too much medication. So how do we tell them apart? We use the Tenzolon or edrophonium test. If giving Tenzolon improves their weakness, it means they were undermedicated, right? So myasthenic crisis. But if the weakness gets worse, they are overmedicated, meaning cholinergic crisis. To spot a cholinergic crisis quickly, just remember the SLUG mnemonic. If you're seeing salivation, lacrimation, which is tearing, urination, defecation, GI cramping, and emesis, you are dealing with a cholinergic crisis. Basically, their body is flooded with too much acetylcholine and literally everything is leaking. The second you see this, you hold their standard meds and give the antidote, atropine. Okay, time to test yourself with some baked-in NCLEX prep. Let's see how this builds into actual board questions. Question 1. A client with myasthenia gravis is scheduled to eat. When should the nurse administer the prescribed pyridostigmine to maximize benefit? Go ahead and drop your answer in the comments. 3, 2, 1. The correct answer is C. Timing this medication about 30 to 45 minutes before meals is absolutely essential. You want the med hitting its peak effect the exact moment they sit down to eat, giving them maximum muscle strength to prevent aspiration. Awesome. Let's try one more. Question 2. Which assessment finding in a client with myasthenia gravis requires the most immediate intervention? Take a good look at these options. 3, 2, 1. And the answer is A. Look,
Drooping eyelids and fatigue, those are definitely expected hallmark findings. But declining respirations and unmanaged secretions, that is an immediate drop everything airway emergency. It trumps all those other symptoms every single time, because respiratory failure is what actually kills the patient.
So, let's lock this in with one final memory hook. MG stands for muscles get tired, and your absolute #1 job as a nurse is to protect that airway. Literally everything you do, from timing meds to watching for a crisis, revolves around keeping those respiratory and swallowing muscles working. As you review your neuro disorders tonight, ask yourself, what other paralyzing condition mimics this, but starts at the toes and moves up? Think about it. If this explainer made it click for you, subscribe. One killer med-surg topic every day until you pass the NCLEX. Keep crushing those studies, and I'll see you in the next one.